afternoon and welcome, everyone. My name is Dr. Sudhir Rao from Pain and Spine Specialists and Shakti Health and Wellness Center. Thank you all for joining us today. This is an educational session. My goal over the next hour is to give you a clear understanding of what causes back and nerve pain, how to determine which cause applies to each patient, and what treatment exists across the full range from a conservative therapy starting point to surgery. We're going to move through three sections. The first is diagnosis. We're going to review the anatomy of the lumbar spine and specific structures that generate pain. There are roughly five. They produce similar symptoms and they respond to entirely different types of treatments. Understanding which one applies to you is the foundation of everything that follows. The second is going to be the treatment landscape between conservative management all the way through open surgical approaches. That range is considerably wider than what most people are aware of, and it includes regenerative therapies, neuromodulation, and several targeted, minimally invasive spinal types of procedures. The third is who's the appropriate candidate? How do we determine whether a patient is appropriate for a given type of treatment, and what type of evaluation process is involved? Please use the Q&A function throughout the presentation rather than holding questions until the end. I'll address as many as time allows. All right. Why back pain matters. Some context on the scope of the problem itself. Back pain is the number one presenting complaint to a primary care doctor's office. Approximately 8 out of 10 adults will experience some type of back pain at some point. That's 80% of people. Globally, low back pain accounts for more than 264 million cases and represents the leading cause of disability worldwide, ahead of cardiovascular disease and even cancer. In the United States, the combined cost in healthcare expenditure and lost productivity exceeds over $100 billion annually. You ask, why do I share these stats? Well, for two big reasons. First is clinically. A condition that is so prevalent is well studied. That means we have a substantial amount of evidence behind spine care, and treatment decisions can be made on the basis of data rather than just guesswork. And second is practicality. Because back pain is so common, it is frequently managed generically, the same initial protocol applied broadly regardless of the underlying cause. That approach resolves acute, self-limited episodes reasonably well, but it doesn't perform well in the chronic setting, where the specific pain generator matters a great deal in order to be able to provide a reasonable treatment and hopefully a better outcome. Chronic back pain is defined as a pain persisting beyond 3 months. At that point, the clinical question changes. It's no longer whether the episode will resolve on its own, it's what structure is actually producing the pain and whether the structure can be treated directly or indirectly. That's the question that this presentation is organized all around. Next slide. Common causes of back pain. Well, let's go through the big differential. There's 5 categories that majority of chronic low back pain comes from. Each can cause significant discomfort in a similar anatomical distribution, which is why history and a physical examination matter more than any one location alone. So discogenic pain, arising from the intervertebral disc itself. Now the disc, I like to relate it to or equate it to a jelly donut. You've got the nucleus, which is the jelly on the inside, and then you have the annulus, which are cartilage rings on the outside. And when that disc starts to get pressurized, it loses hydration, it gets pinched, or it just gets degenerated over time, that disc material can start to bulge out and put pressure on the spinal nerves. Now, discogenic pain alone, pain that comes from the disc, is characteristically worse with sitting and worse when you flex forward. Activities may increase axial load, which causes more pain in the lower back. Patients often report difficulty rising from a seated position, particularly from a low car seat. Then you have facet-mediated pain, which is the facet joints, which are the joints on the sides of the spine. This type of pain is different than discogenic pain. This is usually worse when you're standing, walking, or extending back. It's usually relieved with sitting and forward flexion. Next is radicular pain, or pain that comes from nerve root irritation that radiates down the leg itself, also known as sciatica. Next, you have segmental instability, or bone upon bone, which are no longer stable and they move. And that motion or movement can cause irritation to spinal nerves and cause for significant lower back and leg symptoms. And lastly is musculoskeletal. Myofascial or ligament strain, sprain can cause a lot of muscular spasms that can fluctuate throughout the day and can last for weeks or months. The clinical point in this is that these five presentations require five different treatments. A patient with facet-mediated pain who receives a treatment directed at the disc will not improve. So making sure we're picking the right treatment for the right diagnosis is extremely important. Treating the wrong structure gives us the wrong outcome. Next slide. Disc issues. We're talking about, uh, next slide. We're looking at okay, disc issues in general. The intervertebral disc consists of a tough outer annulus, which is that cartilage ring that I was describing, and surrounding a gelatinous nucleus pulposus, which is the jelly part of the donut. It functions as a shock absorber and permits motion between the vertebral bodies, so allows for motion between the bones themselves, which is the structural integrity of the spine. When you have degeneration, this is really a progressive loss of hydration and disc height with age. This is a normal process, and it does show up on imaging, X-rays or MRIs, and it can be a source of your pain, but it's not what we usually define as a real diagnosis for where your pain is coming from. However, disc bulges are the beginning of that nucleus material starting to bulge out, that jelly coming out of the donut itself, and a herniation is when that jelly donut stuff or the nucleus starts to cause a defect in the annulus and actually compress the nerve root. When the nerve root gets irritated, it can cause pain, numbness, and tingling in the back going down the legs. Imaging is used to help correlate these findings with what we actually see on physical exam and on history. So history is very important, and when by history I mean when we're asking you questions on what does the pain feel like, where does it travel, how long has it been there, how do you rate it, what makes it better or worse. These questions are really geared to trying to figure out what parts of the spine are actually affected and where the pain is coming from. So imaging findings correlate imperfectly sometimes with symptoms. In someone who has no symptoms but with no back pain whatsoever, a substantial proportion of disc bulges are shown as degenerative changes on MRI. So you can have, I should rephrase that. We know that about 30% of people who have abnormal MRIs have no symptoms. So just because you have MRI findings does not necessarily correlate to structural defects that are actually causing you problems. So we don't want to treat an image, we want to treat a person. We want to treat your story, your history, and that's why it's so important to learn more about. Next slide, we're going to be on slide number 5, nerve irritation and instability. One more slide. So radicular symptoms, let me just double check this. Radicular symptoms warrant specific discussion as they generate the most amount of pain in general. So pain that radiates down or starts in the back or the neck and goes down the arms or legs is called radicular symptoms. And this is a mechanism of compression or inflammation of the nerve root as it exits the neural foramen, as it exits the spine itself. This can be caused by disc material, bone spurs, something called the ligamentum flavum getting more thickened, and just swelling and inflammation around the facet joints, crowding the spine where the nerves are exiting. This can cause nerve root inflammation and irritation and can give you pain in the back, radiating down the legs with numbness, tingling, and weakness. So, two questions arise in this scenario clinically. The first is going to be: are there any red flags that we need to be worried about? So, such as, are you losing bowel or bladder function? Are you having significant weakness or paralysis in your legs? If those things are happening, then that becomes a surgical emergency. That could be because you have something called cauda equina syndrome, which is where the spinal cord and the spinal nerves are getting compressed. That's a surgical emergency. We need to get you to the hospital and get evaluated by a spine surgeon, and most likely need emergency spine surgery. Now, that does not happen very often. So short of that, we're looking for, hey, are there other signs and symptoms that could be reversible? Are there sensory changes? Is there numbness and tingling that's either starting or getting worse? This can be measured in days or months. And when the compression gets relieved, it could also take days or months for that to reverse. So meaningful recovery is common. And lots of times these things get better on their own. In 6 to 8 weeks with some physical therapy, some anti-inflammatories and rest, I'd say 80% of sciatica gets better just with time. Our body does a great job of healing. It's the other 20% that doesn't get better is the types of patients that we end up seeing. Now, if you've got, progressive motor weakness, you're developing something called foot drop, where your leg is not able to extend up anymore and it keeps dropping and you start dragging. That could be because a nerve or set of nerves is getting compressed at the spine or down the leg itself. If you're having numbness and tingling in other parts of the saddle area, again, more signs and symptoms consistent with cauda equina syndrome, something that may require a surgical emergency, best to get evaluated. Now, segmental instabilities, when your bones are not necessarily stable because there may be a fracture, there may be laxity in the ligaments, all of which can be concerning and can be where back and leg pain are coming from. We want to get a flexion extension x-ray. We want to get an x-ray that actually loads the spine when you're sitting straight up, and then when you're also flexing forward and extending backward. That's trying to force the spine to move and see if there is something that's actually shifting, in which case we would probably need to approach that with a specific type of treatment, which may require surgery or a minimally invasive uh, style of surgical approach. Next slide. Why surgery isn't always the first step. Now, this is important. We're not saying surgery isn't helpful. Surgery definitely plays a good role in getting people better, but it's also important to recognize that there may be other types of treatments that are available that you're just not aware of yet that could help you. So normally we say, there's four buckets of pain treatments. There's over-the-counter medications. There's prescription strength medications, all under the first bucket of meds. Second, it's going to be physical therapy. The third is going to be some type of interventions, and the last would be surgery. Now, the intervention bucket has gotten a lot bigger recently. We have more tools in our tool belt that can help people hopefully avoid surgery, and we'll get to all of them later in this talk. So, spine surgery has a clear and appropriate indication: progressive neurological deficit, so progressive weakness, progressive numbness, structural instability or deformity, cauda equina syndrome, which we already mentioned. These are signs and symptoms that require surgery. Symptomatic pathology has failed a genuine course of conservative and interventional management. In those settings, surgery is correct recommendation. And when a patient in my practice meets those criteria, that's what we get. We get them to a surgeon and we assist in getting them to the right person to try to get the help that they need. The issue I encounter more often is more in the sequencing of how this happens. A patient presents having been told that a fusion is likely, and on review of the history, the conservative course consisted of a period of physical therapy, some anti-inflammatories, and an epidural steroid injection. That, unfortunately, is an incomplete conservative treatment. That doesn't mean that you are now a surgical candidate. Too often, that person ends up going to be seen by a surgeon and sometimes even has surgery. The interval between the point and surgical candidacy contains a substantial number of other interventions. So we have a lot of other tools that we can offer patients to try to get you feeling better before we need to go and jump to surgery. Four considerations supporting working through this interval first. Recovery. When we use interventional and minimally invasive therapies, our recovery time is measured in days, not months like open surgery. We want to preserve segmental motion, meaning that we want to preserve the ability for the spine to flex and to move in a normal way. Fusion, lots of times, although it provides stability, it limits the ability of the levels to be to flex and extend. This leads to some functional limitations. We want to choose something that's reversible if we need to. Now, most of our interventions, especially the injection therapies and now even the minimally invasive spinal procedures, they're fully reversible. So if there was an issue or it was not providing you the relief you need, we can reverse those out, take them out, or there's nothing left in their body to even reverse. It's just a matter of if it doesn't work, the next step would be spinal surgery. So it's nice to be able to try something that you can either reverse or it does not cause a permanent anatomical change on the spine before we go to spine altering surgery. And lastly, I would say diagnostic certainty is something we want to worry about. Surgery addresses structural pathology, and it does so very effectively. However, the structural finding is not always the pain generator. A technically successful surgery may produce no significant symptomatic changes. So you can have had surgery, and the surgeon can say, wow, everything looks great. We cleaned it all up. I don't know why you still have pain. And too often I see that. So this is a recognized phenomena that happens, and we call it lumbar post-laminectomy syndrome or failed back surgery syndrome. It actually has its own diagnosis, which means that it happens often enough that we need to do something else about it. So it's really important to spend time identifying what the real pain generator is with confidence before moving forward with interventions, procedures, minimally invasive procedures, or spinal surgery. Next slide. Now, natural healing is another approach altogether. Like I said earlier, our body is a very strong organism and wants to heal itself. It does a great job of healing itself. 80% of back pain related issues get better in about 6 to 8 weeks with conservative care. Take some Advil or an anti-inflammatory, Tylenol, take some rest, and give it some time. And time heals a lot of wounds. So our body is already charged up to be able to heal itself, but there are some other natural ways to actually help augment and speed up that type of recovery. I'm getting more and more patients coming to me now saying, I did the cortisone injections, I've done steroid injections, I want to try to avoid surgery. What else do you have for me? I'd like to try more natural approaches, or I don't want to try the cortisone injections at all because I've heard mixed reviews on what that does long term and whether or not that's a good fit for me. So I'm getting more and more patients who are looking for more natural options. Now, when I refer to a natural or biological treatment, I'm referring to interventions that work through the body's endogenous repair mechanisms rather than mechanical reconstruction. So, things that the body can do on its own. I'm not referring to just nutritional supplementation or complementary practices. That's a completely separate discussion. So, the physiological rationale here is pretty straightforward. Tissue repair is an active, well characterized process. There's inflammation, there's a proliferative phase, and there's a remodeling phase. So there's damage, there's cells trying to respond, and then there's cells making changes to recover. It functions reliably in a well vascularized tissue. So when we have enough blood flow to these areas, this normal mechanism happens often. Unfortunately, it functions very poorly in tissues with limited blood supply, like our discs, the and tendons and cartilage. When we don't have enough blood supply, then we're relying on a finite amount of repair mechanisms that the body needs to use and work into. But after a certain amount of time, you may run out of those repair mechanisms and you need some additional help. So regenerative approaches attempt to address that limitation by delivering concentrated biological signaling directed to the affected tissue. So we can use different type of image guidance, ultrasound or X-ray slash fluoroscopy, to guide these regenerative properties, whether it's PRP, ozone, or exosomes, into different tissues, into different joints, and even around the spine to try to get the type of healing that we're needing. Now, what's exciting is that there's more and more evidence that's coming out on how this actually works and how much better people are getting with less surgical intervention. Slide number 8, advanced solutions that work with you. All right, here's the structure of the rest of the talk. We're going to talk about regenerative interventions, which are going to be PRP, exosomes, and ozone. We'll discuss a little bit of neuromodulation, which is magnetic stimulation, spinal cord stimulation, and peripheral nerve stimulation. We'll also discuss targeted approaches, so minimally invasive spine therapies like basovertebral nerve ablation, SI joint fusions, interbody spacers, and facet fusions that all can be helpful with treating spinal stenosis and degenerative disc disease. We'll close with integrative therapies and how we use that to support and maintain our results. For each intervention, I'll cover 4 points: the mechanism of action, the appropriate indications, the expected benefit, and the limitations or contraindications. The last point matters. An intervention with no defined patient selection criteria is generally an intervention with unclear efficacy. So we want to make sure we're picking the right procedure for the right indication. Now, one thing to note is when we talk about back pain, it's complicated. We've gone over the anatomy already. We're going to go over the types of treatments that we have and the indications, but there are multiple mechanisms that affect people's backs at the same time. So to just say we're going to treat one thing for back pain alone and get your back pain all better is usually unrealistic. It's usually a combination of issues that are occurring over years. Short of having a traumatic accident or a fall, we would say that most people's chronic pain comes from ongoing degenerative changes over time. So it could be the facet joints are becoming very arthritic. Your discs are starting to thin out. They're also developing some spinal stenosis in the spine itself. There's some osteophytes or bone spurs growing, and those spinal nerves are getting irritated. That type of combination of symptoms or of conditions I see all the time. And my job is to then figure out, well, what's the most likely culprit? And we're going to start there. But we're going to realize that it's probably just not one thing, it's a process. So chronic pain is frequently managed symptomatically. We use pain medications to modulate or change the pain signaling. We use muscle relaxants to treat secondary muscle spasms. We use steroid injections to reduce inflammation. Each of these has an appropriate role, particularly in acute pain management. So acute pain, again, is one to about 3 months, maybe even 2 months now, depending on who you talk to. But that acute segment responds differently than chronic pain. And so the consequence of pattern, um, the consequence is a pattern familiar to all of you. Temporary relief followed by pain returning, repeated over years without a significant change in overall outcomes. So when we keep doing the same things over and over and you're not getting better, we need to change things to get you feeling better. So our diagnostic approach is structured to try to avoid that. We do an initial consult directed at one single question. What's the anatomical structure that we think is causing the patient's pain? That question is answered through three components. A physical examination where we examine you and we do different types of provocative tests to see where the pain is likely coming from anatomically. We look at imaging, whether it's x-rays, MRIs, CT scans. We're looking to see what's out of whack and what's abnormal, and which of those abnormalities correspond to where the pain is coming or where the pain is felt by history. And lastly, we do different types of diagnostics to help with that. And these diagnostics could be EMG NCVs, which are nerve tests. They could be nerve blocks, all of which can help specify which nerve or nerves are causing the problem, which areas of the spine itself are causing the problem. Now, based on these results, we then can come up with different types of treatments. Next slide number 10. We're going to start with PRP, platelet-rich plasma. Now, PRP has been around for a long time, but the data continues to grow and continues to show us that it works really, really well for mild to moderate inflammation. And that could be inflammation in a joint, which is arthritis. That could be inflammation around tendons, muscles, or ligaments, and or even around the spine. So what is PRP? Well, PRP is really three components. We draw your blood, we spin your blood, and then we take the plasma part of it, which is full of growth factors, and we inject that. Who's a good candidate? Well, arthritis of any type. So facet joint arthritis, which is on the sides of the spine, a sacroiliac joint, which is the joint where your pelvis meets your tailbone, that can be very inflamed and arthritic. Any type of tendinopathy or tendinitis, any type of ligament injury, any type of joint pain with arthritis, and some types of disc-related issues. It's reasonable to start with corticosteroid injections and see what type of response you get. If that doesn't give enough relief or doesn't give you long-lasting relief, then the next step could be to consider PRP. Now, PRP can take up to a month to kick in. We can repeat it a month later if you're not getting as much relief. But if that's not giving you the type of relief you need in the end, then we may want to consider the next step up, which would be exosomes, which we'll get to in a second. So what are the limitations of PRP? Well, insurance coverage is challenging. and usually it's not covered by insurance. Blood thinners may alter how your body processes the plasma and how effective that plasma is. So it may not be a good candidate if you're on blood thinners. If you have chronic NSAID use, then we're going to tell you to stop using them for about a week before and probably a week or two after to make sure that the blood properties are as as healing forward as possible. Safety profile is great because it's your own blood. So we're not worried about any type of cross reactivity or rejection. It's your own blood, so you should have no problem with it. And there's always potential procedural risks with any type of procedure, but we do them under X-ray and ultrasound guidance, and we have a tremendous amount of experience using these types of imaging guidance techniques and treatments to hopefully minimize any potential risks. Next slide, exosomes. Now, exosomes have been around for a while, but they've become more popular in the last, I would say, 5 to 10 years. Exosomes are extracellular vesicles or little blebs that come off of stem cells, and they're released by cells as a means to cause some intercellular signaling to allow cells to communicate with each other. They carry proteins, lipids, and messengers, and something called microRNA. The signaling then mediates modulation of inflammation. It allows for changing of inflammation and inducing tissue repair within cells. The therapeutic rationale here is that if we have a concentrated signaling to tissue that forces our own body to start ramping up the autoimmune or inflammatory or healing systems, you're going to get a significant result. Now, there is preclinical and laboratory data that is becoming more and more substantial and compelling. Our experience with using exosomes starts back during COVID, uh, right when patients were unfortunately on ventilators and were in the prone position. We started getting involved with using exosomes that had been trialed in these types of settings, and they had shown a profound decrease in inflammation in patients who were in end stage lung disease because of COVID. So that gave the labs about 50,000 patients of patient experience and with very limited side effects. So worst case scenario, it doesn't give you any relief. Best case scenario, it helps you specifically with exactly what you're looking for and what you need help for. Now, the evidence continues to improve. We are starting to see more large randomized trials come out that are showing positive findings on how exosomes work. Now, all exosomes are not the same, so it's important to figure out where the exosomes are being sourced. Has there been any confirmation on what type of testing by a third-party vendor for that exosome to make sure it is the type of product that you think it is, and it's not covered through insurance. So these would be the limiting factors to be on the lookout for. But talk to your providers about different types of options, and if you're a good candidate for exosomes. I've had patients who've been able to use exosomes to avoid nerve surgery, joint surgery, spine surgery. People have been able to recover from injuries within weeks or months instead of 6 to 12 months at times. So we've seen some really compelling changes by using exosomes, and it's becoming a bigger part of our toolbox. Next slide. Ozone therapy. So ozone therapy is pretty cool. Ozone has been around forever. It's getting more attention now. Medical ozone, which is O3, is is meant to increase oxygen availability into the tissue, decrease inflammation, and stimulate antioxidant enzyme systems. It's really meant to help heal and decrease inflammation to get you to recover from whatever type of injury you may be dealing with. So we can use this intravascularly, which means we can give you an IV ozone therapy. We can also inject into joints around tendons and ligaments. So it's a very cool type of therapy that has become more popular. It's indicated for disc pain, facet-mediated pain, any type of soft tissue or joint condition. It's frequently combined with other therapies, but it can also be used alone. More evidence, especially in Europe, is out there on ozone. The United States is starting to get more open to it, and it's something that we're introducing into our practice now. And we're excited to see the type of results that we're excited to see the type of results that we've been getting. Um, it's quick, the downtime is minimal, the risks are minimal, and it's a reasonable option if you're either trying to avoid corticosteroids or if they're not working for you. Next slide. Neuromodulation in general. So neuromodulation is meant to use stimulation, electrical stimulation or magnetic stimulation to change the way the nerves are sending signals. So in general, we know that nerves get injured in our body, and that injury can be caused by a bunch of things we've already talked about. It could be caused by in the spine. It could be caused by discs, bone spurs, arthritis, stenosis or narrowing. In joints, it could be from the joint itself becoming so degenerated and arthritic that it can't function and causes a lot of pain. And the nerves around the joint are the ones sending those signals. So if we can modulate or change the way these nerves are sending signals, we can get really good results. So spinal cord stimulation specifically has been indicated for lumbar post-laminectomy syndrome or failed back surgery syndrome, um, chronic limb and trunk pain, complex regional pain syndrome or CRPS, and any type of vascular issue in your legs. So you're not getting enough blood flow to legs. SCS or spinal cord stimulation has been indicated for those four conditions for a long time. More recently, in the last 3 years, diabetic peripheral neuropathy has also been indicated. And we've been using it to treat nerve pain forever. So it's great to now see that the insurance companies are also agreeing that this is a reasonable next step, especially for such a condition that causes so much pain. So for patients who have failed Neurontin, gabapentin, Lyrica, Cymbalta, or other nerve medications, stimulation in general is a great alternative option. And what's really cool and exciting about stimulation is that whether it's spinal cord or peripheral nerve, and peripheral nerve is going to be more for the joints themselves, smaller nerves that are not responding to spinal cord stimulation. But either type of spinal cord or peripheral nerve stim, you get to do a trial first, which means you get to test drive this therapy before you actually buy it. It's one of the only things in medicine that you get to take out for a spin, see if it works for you with minimal risk, and then we get it implanted through a surgical option. So we're looking for about a 50% improvement with the trial. And the trial is just really placing a wire, a flimsy little spaghetti-like wire, either into the spine or around joints, around these specific nerves. It takes 15 minutes to do the trial. We just tape it to your back. There's no incisions. There's no sutures. We tape it around the joints or around the nerves or around the spine, and then you have a remote control that controls the device, and you get to try it out for 3 to 7 days. And we're looking for improvement in pain, so a 50% improvement in pain and improvement in functionality. So you get to tell us at the end of the trial if it worked. Is it worthwhile for you to then move forward with implanting the device? So this is one of the few things that we rely heavily on your input, and only is it your input that determines what the next step is. So we've had excellent success with spinal cord and peripheral nerve stimulation. I'm very excited to say that on the peripheral nerve side, things are getting more advanced. We're getting better types of products that we can use, and we're getting better programming. So we're having access to more nerves that are more subtle and getting better results. And on the spinal cord stim side, things have continued to improve. The technology is amazing. There's technology that mimics our own nervous system out there now. There's no longer the buzzing or tingling sensation. So the technology continues to improve. And I'd say if you've tried this in the past, like 10 years or longer, and you said it didn't work, you didn't like how it felt, I would highly urge you to consider trying it again, just a trial, if other things haven't worked. So talk to your doctors about that as well. Next slide. This is called the Intercept procedure, but really, the Intercept is a specific name brand. It should be basovertebral nerve ablation. So BVNA or basovertebral nerve ablation is the name of the procedure, the type of the procedure. And this has been around for several years now. The person that's an ideal candidate for this is someone who has failed other types of conservative treatments. So you have chronic back pain that's not responding to epidural steroid injections, physical therapy, radiofrequency ablation, um, maybe even spinal cord stimulation, and you want to try to avoid back surgery, then we should consider the BVNA procedure. And so we're looking at MRI changes. We're looking for something called modic changes, MODIC. If you see that on your MRI report, that's something to bring up to your doctors to say, hey, would I be a candidate for this? So we're using radio frequency energy here to heat the basovertebral nerve, which is the nerve inside of the bone. And if you heat it, it permanently damages that nerve, and you should get pain relief fairly quickly. So we're seeing people do significant more activity 3 months after this procedure than we've ever seen before. And the nice thing is there's several companies who've come out with their own versions of this BVNA procedure. The procedure itself is becoming more efficient. The burn time with the heating time has decreased, and the procedure time itself has become lessened. So people are getting better outcomes with less time on the table, which is important for us to consider. There are good studies that have been published on the efficacy of these types of procedures. So if you've got what we call vertebrogenic pain or axial back pain that hasn't responded to radiofrequency ablation or epidural steroid injections, you may be a very good candidate for the BVNA procedure. One thing that we have, so next slide is going to be minimally invasive spine procedures. So in general, we've talked about disc herniations, we've talked about arthritis, we've talked about disc or bone uh, problems, and we're going to talk about spinal stenosis now. So spinal stenosis continues to be a significant issue for most of us as we get older. And what spinal stenosis is narrowing of the spine. So we have a spinal canal and we have nerves that come down and go out at each level. But over time, that ligament can get thicker. There could be bone spurs growing on the sides. There could be discs that are bulging back. Instead of a canal being this big, it becomes this big. When it gets smaller, we have more difficulty with getting nerves through and sending the signals. So it gets more difficult to stand and walk. It gets better when you sit. Sometimes if you push a shopping cart or a walker, you can walk all through Walmart without that shopping cart or walker, without flexing forward and opening up that space. You can't walk at all. So that's textbook shopping cart sign, and that's textbook spinal stenosis. Historically, we would do an epidural steroid injection, some physical therapy. If that didn't work, then we'd send you to the surgeon to have surgery. And that surgery would include opening up the spine, doing a laminectomy, or even a fusion. But we have had progress with minimally invasive therapies, and now we have several tools that can hopefully avoid spine altering surgery. So we can have something called the mild procedure, which stands for minimally invasive lumbar decompression. It is a way to come in and sculpt out some of the ligament that's gotten thickened over time. We do this as an outpatient procedure. It takes about 30 minutes to do. We use X-ray to help us guide the needle and the tools into the right spot and open up that space. No implants, no bone resection, no fusion, no general anesthesia either. So either local anesthesia or maybe some light sedation. It takes 30 minutes. It's been around for a long time now, and we're getting good results with it. So definitely something to consider if you have spinal stenosis, you've got pain when you stand and walk, that gets better when you sit. Talk to your doctors about that. Now, if you've got degenerative discs that have not responded to epidural steroid injections, they may want to think about intradiscal injections. We're now using amniotic fluid membrane to be able to inject into the disc itself, seal that disc off from leakiness, and give it more hydration or more disc height. And this is allowing patients to have better ongoing results, especially for people who have failed epidurals but want to avoid surgery. So been doing this for about 3 years now with excellent results. So it's definitely something worth considering and asking your doctors about intradiscal injections to see if you're a good candidate. Now, interbody spacers is another option for spinal stenosis. If the mild procedure doesn't give you enough relief, then you may, or maybe it's just too severe of stenosis, we want to consider putting in a spacer between the spinous processes, which indirectly opens up that space and makes the spinal canal a little bigger, giving those nerves a little more room. What's listed here is called the Aurora Zip system. That's one of many systems that are out there now that can help with this specific type of problem. There was something called Vertiflex that used to be around for a while. It's off the market now, but there are a lot better, newer systems that work better and can give us a longer type of relief. Some of these systems can even help with spondylolisthesis or when there's spinal instability or slippage, and we can help stabilize the spine through a small incision instead of having major spinal fusion surgery. So definitely something to consider and ask about. Patient selection. Definitely important making sure that we've ruled out other causes of symptoms. We've tried other conservative therapies, and we have come to this as the next or maybe late step in treatment. Next slide. Still further continuing with advanced procedures here, kyphoplasty is something where we can cement compression fractures. This procedure has been around for a long time. If you have osteoporosis or you've fallen recently and you have a compression fracture in the spinal bones themselves, we can put a balloon in and put in some cement and seal off that space, even improve the disc height a little bit and get rid of that severe pain almost instantaneously. So it's a great procedure because it can actually give you real-time relief in short order. So if you have a compression fracture, make sure you seek someone out who does this procedure. And SI joint dysfunction. So sacroiliac joint dysfunction or sacroiliitis is becoming more popular over the last 3 to 4 years. This is where you have low back pain, hip pain, groin pain, even buttock pain or leg pain. It is arthritis in the SI joints, which are the joints where the tailbone meets the pelvis itself. Now, we do SI joint injections with steroids. We used to do radiofrequency ablation of those joints, but it's no longer covered through insurance. So we're now offering patients who respond to SI joint injections on a temporary way with the SI joint fusion. And now the fusion used to be some big major orthopedic spine surgery. That's changed a lot in the last several years. Now we're fusing these SI joints through a little tiny incision using X-ray, and this is a 30-minute outpatient procedure. So people are getting excellent results with this if you're the right candidate. If you are and you feel like this might be something worth considering, make sure you bring it up to your doc. Next slide. Integrative therapies. So, you know, we want to make sure we're looking at other ways of trying to get relieve your pain, reinforce muscular integrity, rehabilitate, and repair underlying issues. So when we talk about integrative therapies, we're looking at treatments like acupuncture, where we work on meridians to help the nervous system and pain signaling to improve. We can also use something called the biocharger, which is a personal favorite of mine lately. Biocharger works on optimizing how our body sends signaling throughout our own body. It works on four tenets: uh, light, vibration, pulse electromagnetic frequency, and I always forget the fourth one. Uh, It'll come to me, but it works simultaneously. So you sit in front of this system for about 9 to sometimes 15 minutes, depending on what type of program you've chosen. And it helps the electrical currents in your body get more in tune and become more efficient. So it can help with rest and recovery post workout. It can help with injuries. It can help with post op recovery, anxiety, energy, fatigue, and pain management, amongst a bunch of other symptoms as well. So definitely worth looking into more photomodulation, biocharger types of therapies, and seeing how that can help restore your health. The newest treatment option we're offering is called the M-Sculpt Neo. Now, the M-Sculpt Neo traditionally was a body contouring device that was meant to help with more aesthetics, but we've realized that it has a functional component using magnetic stimulation and radiofrequency energy. So we're now able to rehabilitate muscles, more smaller muscles, to get them to function at a stronger level. We're able to bring in more collagen into joints that have been damaged. So this is great for athletes who are recovering from an injury. They may not be able to weight bear on that joint because of the injury or their spine. We can stimulate these muscles above and below the joint and actually lead to increased muscle mass and strength while you're recovering by resting the joint but stimulating the muscles around them. And we can help change the way the nerve sends a signal. So it's great for diabetic neuropathy or any type of neuropathy. It's great for people who've had golfing and tennis injuries, baseball injuries, football injuries. Many professional sport teams have this device now and are using it for their professional athletes. So combining the sculpting, which in a 30-minute session can lead to 20,000 muscle contractions. So you get a significant amount of strengthening with the functional component, which uses a more delicate approach by stimulating specific muscle groups and nerves to get you the results you're looking for. So this is definitely going to be a game changer. The more we learn and the more data that's out there, the better. This is FDA cleared for lower back pain, for diabetic neuropathy, and joint pain. So we've got a lot of good uses for this, and definitely going to be used as a big part of our non-surgical treatments. And then we have structured rehabilitation, which MSculpt does as well. So, rehabbing your muscles is important. Improving blood flow to the tissue, improving strength, and improving bone strength is extremely important, especially as we get older. So, working out regularly, having a structured program is important, but doing it safely is the ultimate importance. So, either work with someone who understands injuries, understands spine, go to a good physical therapist that you trust and has a good reputation, but also consider incorporating the MSculpt Neo into that treatment plan, because you can get to you can really help with the overall outcomes by utilizing all these therapies. Slide 18. So I want to close the clinical portion with a note on outcomes, because that's how they're framed. Outcomes in spine care are not uniform. They are not primarily determined by which procedure is selected. They're determined by the diagnostic accuracy, by appropriate patient selection, and symptoms duration prior to treatment. So we want to make sure we're picking the right type of patient for the right type of procedure, which is really what's going to lead to the best outcomes. So how long has your pain been there does matter. Longer standing pain generally responds slower, and in part because there's something called central sensitization that sets in. That's our own nervous system getting so used to that pain signaling that it actually amplifies the pain signals in our brain. And to turn that volume down can take some time. So the sooner we address these pain signals, the better it is, because it's going to be more likely for you to have a better outcome quicker. And then having realistic goals are really, really important, right? So we need to discuss what type of goals you're looking at with where you want to be. We're probably not going to get a full elimination of all symptoms. We're going to hopefully get a significant reduction of pain, but improve your functionality. So if we can decrease pain, improve functionality, that's our end goal, and that's what we're always shooting for. Okay, this concludes the talk itself. We're going to move on to a Q&A. So Jake, can you open up the Q&A?
Yep, I have that slide open. Everyone can navigate to the bottom of their screen. They'll see a Q&A tab where you can start typing in your questions. We've got a couple questions in there already, and we'll get started shortly. And I also see that
Well,
there's a couple of you that are raising your hands. Um, Once we get through some questions, we'll allow you to speak, and you can just ask your questions over voice.
I'm going to start with the Q&A that's in here. It's a question about, I've had spinal stenosis and degenerative disc disease. I've had injections years ago. I decided to lose weight and take the load off of my spine. I don't have any back pain or leg pain right now, but I want to know if there's anything else I can do to protect my spine. So I would say I'm glad that those other symptoms have improved. We're talking about millimeters of change to make those changes happen. So we get a little couple millimeters of less inflammation, less nerve irritation, a little less arthritis here. It can have a profound effect on your spine. But the goal is to make sure that we're taking care of our spine for the long haul. So how do we do that? I would say exercise is going to be your best friend. Whether it's structured exercise, it's pool therapy, it's physical therapy. Using the MSculpt Neo is another option where the device does the work for you. There's other ways. So I think staying active, being cognizant, being aware that you have a bad back. So don't pick up that couch. Ask for help. Remember how to bend properly. These things that I think we all know, but we sometimes forget because we get into the thick of things. Gets a little challenging. So I think the importance there is keep your core and your back strong. So focusing on that would probably be the best thing for you to do now. Is the biocharger like a TENS unit? No, not at all. So the biocharger, a TENS unit is a little portable device that has pads that stimulates muscles. And by stimulating muscles, we're increasing blood flow to the muscles, but we're also blocking nerve signaling. Biocharger is completely different. It doesn't go on your body. You actually sit or stand in front of it, and you absorb the vibration, the light, and the pulse electromagnetic frequency goes into your body. So our body uses all of those systems on a day-to-day basis to send signaling. But sometimes the toxins that we ingest, the trauma in our lives itself, can cause for abnormal signaling. The biocharger helps reset that. It's also called grounding. So some people will go outside and walk barefoot, and that helps ground your body, get some negative electrical energy out of your body. The biocharger does that as well. Next question, which of the modalities are appropriate for instability and slippage in the lower cervical spine? Now post open cervical fusion with hardware above the current painful area. Ooh. Unfortunately, nothing I described on the minimally invasive spine side yet is indicated for the cervical spine. In this scenario, I would say considering epidural steroid injections, medial branch blocks or facet blocks, and radiofrequency ablation at the non-operative area may be a good place to start. But if there is cervical spine instability, then I think you should consult with the surgeon. Next, can any of these options address spinal compression due to multiple myeloma? Spinal compression due to multiple myeloma is, unfortunately, a difficult nerve-related condition that can be difficult to treat. Um, in general, I think focusing on modalities that can help with nerve processing and nerve signaling is probably the best way, whether that's through medications, through injections, like steroid injections, trying to figure out specific nerve roots, or spinal cord stimulation, peripheral nerve stimulation, or magnetic stimulation may be good options to try to get to the specific nerves and quiet them down. So my recommendation would be to consider, if medications have not helped, then consider different types of stimulation to help there. I've heard of arc wave therapy that has been successful for baseball players. Is that something you're aware of, and would you explore? Unfortunately, I'm not aware of this. Definitely willing to explore and learn more about it. This might be something. Well, I am familiar with therapies that can help modulate your autonomic nervous system. So your sympathetic and parasympathetic, sympathetic being fight or flight, parasympathetic being rest and digest. When those systems are out of whack, it becomes difficult to deal with a lot of different body functions. It can lead to more pain. It could lead to difficulty in concentration as well. So there are different therapies that can help balance and improve our parasympathetic tone. But I could look into ARP wave therapy and get back to you. If nerve compression is the issue, are you able to see the location of the compressed nerve on an MRI or other radiological exams? Yes, you can. So there's a couple different ways to do this. So we can use MRI, CT scans, or different types of imaging to identify where the nerve is getting compressed. MRI probably is the best way, but we can also do EMG nerve conduction tests to map out where that nerve is getting compressed and which nerves are getting compressed. So there are ways to be able to assess what's going on, which those nerves, and how to better treat them. Next one, do grounding sheets work? I think they do. The concept of grounding itself, if I believe I understand this, is about getting different types of negative energy and out of your system. And so you can use the biocharger for that. You can walk around barefoot on grass. There are different sheets out there that are supposed to take that energy away as well. I think all of them are reasonable options. I've got degenerative bone disease that allowed pinched nerve from my C4-5. Pain is mostly managed with gabapentin. What's the best treatment to avoid taking meds or to lower dosage? In that scenario, I would think about an epidural steroid injection to begin with. I would think about peripheral nerve stimulation or spinal cord stimulation, as well as magnetic stimulation. So I think neuromodulation could be helpful. I think traditional steroid injections could be helpful as well. I'm having the spinal cord stimulator done in a few days, but only had a 3-day trial. Is it best to have a 7-day since the pain is not always present, mostly sitting in long car rides? Tough question. I think it really comes down to during your trial period, and I think a 3-day trial is fine. During your trial period, did you get 50% or better relief, even if it was for a short period of time, especially with pain that comes and goes. It's hard to catch it sometimes. But if you felt like it did help you with your pain and your functionality, then I would say, and you felt like that was a successful trial, then I would be comfortable with moving forward with the permanent implant. Best treatment for psoriatic arthritis and spondylitis. I don't routinely treat psoriatic arthritis. I do refer to rheumatology for both the conditions, but in general, we're looking at ways to decrease inflammation systemically. And we've had some good success with exosomes intravenously for that. We've used we're starting to use ozone therapy as well. So I think if you're looking for regenerative therapies, we may have some options to try to get that inflammation, especially the systemic inflammation, to improve. I had a trial for a spinal cord stimulator and it decreased the pain by 90%. However, after the actual stim was implanted, there was no improvement, even though it was adjusted several times. Ugh, that's awful. I'm very sorry to hear that. That's very unusual. If you had such significant relief during the trial, we would expect to have a similar response with the permanent implant. Um, I think you're doing what needs to be done, where you're following up with the representatives and the team to reprogram the device and see if we can get some better relief. I would say if that's not helping, then it may be time to follow up with the implanting the doctor to see if there's any issues with where the wires have been placed. I need pain relief and nothing is working anymore, including pills. They just don't last that long. I'm approaching max dosage. I've had a prior spinal cervical fusion, and now they want to fuse below. I have stenosis, bad back. I can only stand walking for 5 minutes. I've had MRIs, injections, feet and leg pain. I've been on medications until PT won't help. I'm sorry to hear this. Um, I think a stimulator may be helpful here as a way to try to get to managing or modulating the pain signaling from the spinal cord to the brain without having to mess with medications. Um, Exosome therapy may be also a good option to inject around the facet joints to help decrease inflammation there as well. Again, ozone or any of these other regenerative therapies we discussed could be helpful.
All right,
Did I miss any?
we just have two raised hands. So I'll start with Ray. He's had his hand up for a while. Ray, I'm just going to allow you to talk. You can ask your question.
You're muted still.
You should get a prompt to unmute. Ray, you still there?
You could always email us.
We're going to go over to Crystal. Crystal, you had your hand raised?
Yes. Can you hear me?
Yes.
Yep.
Um, I wanted to see what options that could be done for me now at the stage where I'm at. I had I've had an infusion in my neck. I have disc degeneration and it's spreading, and I have bone spurs and a ton of pain like all the time. It used to not be all 24/7, but I have that now. And now it's affecting when I stand or when I walk. And I've tried the injections. I've tried therapy. Um, Basically, the last specialist that I went to go see at the local hospital that's really well known, they basically said that I need to, because the front of my neck was already had the surgery, they're going to have to go in through the back, and it's very serious, and it's like a 7 month recovery, and that's the only thing that would help me. But I really, really, really don't want to do that, and I've canceled it twice. So I'm trying to figure out what else can we do so I don't have to have another infusion and have a 7 month delay in my life.
Yeah, that's one, I'm sorry you're dealing with all this. I think you fall into that regenerative therapy category where the traditional injections and surgery have not given you as much relief as you need, or want to try to avoid further spine altering surgery. Considering PRP, ozone, and exosomes around those joints may be very helpful. Even intravenous ozone and or exosomes could be helpful to decrease inflammation throughout your body. I think that's worthwhile discussing.
Okay, thank you.
You're welcome. One thing I wanted to add that we missed on this for this talk was hormone replacement therapy has been also been very helpful. After age 30, we start losing, men start declining with hormones after age 30, and women more around perimenopausal area time. And we there was some significant studies published last year that revolutionized how we think about hormone replacement therapy. And unfortunately, the medical field has been doing a very bad job with it for over 20 years based on data that was published 20 years ago. Those studies have been redone and have been redacted or retracted. And so the new results are saying that hormone replacement therapy can be very helpful. And the potential risks, the cancer risks that were scaring people before, have to be re-looked at and discussed for only specific types of conditions. So for the most part, people may do well with hormone replacement therapy, and we know that chronic pain gets a lot worse when your hormones are imbalanced. So one thing that we have found to help many people is replacing hormones has led to decreased inflammation, better, less brain fog, better sleep, better recovery, better rest, and better muscle mass. So thinking of getting your hormones evaluated, which is a simple blood test, could be very helpful. Taking that to your primary care doctor and reviewing that with them, and or if you're not getting the results that you want with them, come our way and we can review them for you.
All right. Well, I think that does it for questions. Like Dr. Rao mentioned in the beginning of the presentation, we're going to be sending everyone a recap of the full webinar video. We're also going to include the slide deck, so you'll be able to download and review that as well. And then we'll just include links to like resources that were based on the treatments that were talked about and some of the other topics. And then in that email, there'll be buttons to contact us or get in touch if you have any questions that come up after reviewing the email. But we appreciate everyone coming, and you'll get that email shortly.
Thank you for everyone's time, and hopefully this was helpful. If you have any questions, reach out to us.